It's a revolutionary idea, and probably is an important part of why cardiovascular disease rates have come down since that time, along with reduction of smoking. So the age of apathy was over. The hypertensionistas were extremely excited about their victory over hypertension, and justifiably so. I think, so they pretty much eliminated the idea of ignoring high blood pressure, which is great. I think what they did in their publications is basically get rid of the term malignant hypertension, and I think the reason they did that was because they didn't want doctors thinking, oh, malignant bad, benign must be good. I'll just leave benign hypertension alone. So they didn't talk about it at all in their publications, and I think that ended up leading to problems. So we're almost there. 1984, this is the third report published by them. They sort of extended their triumph over hypertension and waded into a new swamp, which was the acute treatment of hypertension. So everyone needs to be treated, but is there a group that needs to be treated right away? And who are they? And how fast do we have to treat them? That's a data-free zone. To this day, that is an evidence-free zone. Except for things maybe like aortic dissection, where it's clear that treatment needs to be done right away, there's really no data on who should be treated quickly for high blood pressure, even in the setting of obvious cardiovascular emergencies. Maybe acute pulmonary edema. There's some data. So a data-free zone. This was all basically put together by a bunch of old white guys sitting around a table, and as an old white guy, I see the appeal of that policy, but it's not really justifiable. So they constructed the sort of bizarro framework that we're living with today. So they said, everybody with a blood pressure over 180 is in crisis. I don't know, based on what, I don't know, but it sounded good. There were two kinds of crisis. One was emergency and one was urgency. And because they couldn't talk about malignant hypertension anymore, they kind of stuck it together with the acute cardiovascular complications. So you've got MI and dissection and acute pulmonary edema, ischemic stroke, intracranial hemorrhage, eclampsia, hypertensive encephalopathy, all obvious symptomatic acute cardiovascular emergencies. Some you want to reduce pressure, some you don't. But they're all sort of ultimately caused by hypertension in one way or the other. And they kind of smush that together with slowly developing renal failure and retinopathy. Those are emergencies. And then everybody else is an urgency. Again, no data, just seemed like a good thing to do. It's important to realize that what they meant by urgency and emergency was how quickly do you treat them. Like those folks, they decided had to be treated within an hour. Evidence-free, why not? Okay, within an hour. And these folks had to be treated within 24 hours. Again, just because it seemed like a good thing to do. So when this system got published and went into the wild and clinicians started using it, this, I think, is where things got really confused. I think clinicians decided that hypertensive emergency was a disease, that it was a disease that included all of the acute cardiovascular emergencies, MI and dissection, and it also included the symptoms of malignant hypertension, renal failure, and retinopathy, and it all needed to be treated within an hour. And it sort of implied that all of those things were caused by malignant hypertension. And if you read articles, there was actually one in the Emergency Medicine Journal that Dr. Flomenbaum edits last month about hypertension and how you treat it. You see the same confusion. Everybody sort of starts the same way. They say, let's talk about how you treat hypertension in the ED. And they start with the autoregulation in the brain and small vessel disease and fibrinoid necrosis. And then they talk to you about treating MI and dissection, which have nothing to do with those. But they're all kind of grouped together because of this framework. And then urgency, if urgency is a disease, well, it could be symptomatic or not. And that's how you get this sort of crazy idea that if you've got high blood pressure and you've got a symptom, even if you find nothing wrong, that's symptomatic urgency. Just an imaginary disease that doesn't exist. So that's the the sort of situation we're stuck with today in the hypertension world. So, okay, does that make sense? It's a confusing, winding story. I have to admit, it's confused me for a long time. But basically, the key problem, I think, is this idea that urgency and emergency are diseases, and that the emergency disease is really malignant hypertension gone wild, causing all of the urgent complications of hypertension, which is not true. And then the other mistake is that there's a disease called urgency that can be symptomatic or not. That hypertension by itself, even if you find nothing wrong with the person, is causing all kinds of symptoms. Shortness of breath, nausea, chest pain, headache. There's no evidence for any of that. But it's kind of gotten firmly ensconced that there are two diseases called emergency and urgency that cause these problems. And that, I think, is ultimately the outcome of this whole historical process of really trying to push for treatment, kind of got us into this kind of weird mess. So let me just show you a couple of cases of this at work. This was a patient sent to us last year by a PMD. And you don't have to read all this, but basically, it's a young woman, she's healthy, she's not feeling well, she thinks she has a sort of perimenstrual dysphoria, she gets depressed, there's some issues about her psychiatrist, she's lost a little bit of weight, but not losing any more weight. She's basically in for a kind of a visit with her PMD to talk about some issues. But the PMD finds that her blood pressure is 240 over 130, and then repeats it, it's 220 over 120, and panic ensues. So her exam is fine, gets an EKG, which shows LVH, which is not surprising in someone with what looks like pretty impressive hypertension. We don't really know how long she's had it. And the assessment is hypertensive urgency, needs ER evaluation to rule out emergency. So needs retina examined, may need non-contrast head CT, needs UA labs, needs urgent lowering, will follow up post-discharge from the hospital. So what's going on here? What is this person worried about? So I would say, jumping in, that really she sounds like she's worried about malignant hypertension, but she doesn't use the phrase. But that's really, I think, what she's worried about. She's worried about something with the retina, something with the urine, and that's perfectly legitimate. Is this young woman one of the 1%, as it were, who's actually got small vessel, quote unquote, malignant hypertension? Maybe. It seems unlikely. They usually don't feel well, and this woman pretty much feels well. But she could, and you could make an argument when someone strolls in with that BP of saying, you know what, I'm going to send you to an ophthalmologist and have a look at your, have a good, careful look at your retina. Okay. And we'll check your renal function and make sure you don't have the renal changes of small artery disease, like you don't have a creatinine of 3. Okay, that's fair. But then it's because people don't think in that way, it's mixed up in all kinds of stuff. She needs to rule out an emergency, like what other emergency? Head CT, why? Looking for what? She doesn't have stroke symptoms. There's no acute emergency clearly with this patient. She's not having an MI or a dissection or an intracranial hemorrhage or a stroke. She's not encephalopathic. There's no cardiovascular emergency going on, but because nobody talks about malignant hypertension anymore, she's got an emergency, a confusing emergency, and gets dumped in the ED. I actually saw this patient, and she was fine, and I got into a little thing with the PMD. Unfortunately, I didn't handle it very well. But we sent the patient out, and we called the PMD and got into a little fight. Because we thought, and it wasn't just me, we thought, okay, start meds, start hypertension meds, and we checked a creatinine, it was fine. I looked at the retina for what that's worth, and it looked okay to me, but the patient had no changes in their inner vision. But, legitimate if send her to an ophthalmologist and have a look, because she's clearly got what looks like severe hypertension, needs to be treated.
Do we know what you spoke to the doctor?
history? No. I think she hadn't. I think she had been there several years before and had been normal, like 4 or 5 years before. So hard to know what the trajectory was. Yeah, I mean, she didn't carry a diagnosis of hypertension. She'd presumably been checked sometime in her, in her adult life. So maybe new. Some of it may be white coat and labile, and maybe when she relaxed.
How was the blood pressure in the ED?
In the ED, it was lower. It's like 180 systolic, like 180 over 100. So high, real, I think. Worth treating for sure. But I think this is kind of an example of the confusion that comes out of not thinking about the physiology and sort of thinking about these categories. And then one other case, and then I will stop haranguing you guys. So here's an example of the confusion caused by the word urgency. So this patient we saw in the evening, 79-year-old guy, kind of one of these tough Italian guys. I love them as patients, they're great. History of hypertension, history of bladder cancer, doing very well. He was cleaning something in the basement of his house with turpentine. I don't remember what it was. But a few hours later, he kind of felt queasy, got a little sweaty, got a little nauseated, felt a little dizzy, got a little chest pain. He thought it might be the turpentine fumes, but he did what every God-fearing American does when they don't feel well. He reached for the blood pressure cuff and checked his blood pressure, and it was high. His systolic was 200, so he took an aspirin, and he took an extra dose of his losartan, and he called his son, and his son came over and freaked out and called the ambulance and brought him to the emergency department. And this is his, I don't know if you can see it, this is his little sign in at registration. So the number one complaint is his blood pressure, which as you can see, 8 p.m. it was high, 9 p.m. it had come down a little bit. It was pretty high when he came in. And then he was also dizzy, and then he was also sweaty, and he also had a little bit of chest pain. But he felt pretty much all better by the time he was seen. And the primary concern in the case was the chest pain, and he ended up getting admitted to the medical service to rule out MI. Fair enough. And this is the medicine team's assessment of his situation. Nausea, vertigo, and diaphoresis in the setting of severe hypertension, most consistent with, I guess, symptomatic hypertensive urgency. So I would say there's a problem with this. It's a lovely diagnosis, but as I've been sort of haranguing about for the past 45 minutes, there is no such disease called hypertensive urgency. Whatever it is that's causing his symptoms, it ain't that. It may be nothing serious, it may be something serious, but it's not the high blood pressure. But anyway, that was not their assessment. They kept him overnight, they ruled him out, he felt better, they upped his hypertension meds and sent him home the next day. Whoa, no. So went home. That night, he felt worse. His right leg was kind of weak and numb. And the following morning, his arm was weak and he was having trouble moving it as well. And he waited another day because he's a tough Italian guy. But came back then 2 days later to the emergency department with a markedly weak arm and leg. And of course, he had a stroke. Yeah. He was a hypertensive who was dizzy and had a progressing stroke. There's his, if you can see it, there's his little medullary infarct, like a Wallenberg sort of infarct in the medulla, medial medulla, which explains his dizzy vertigo. And as it got worse, probably not helped by the inpatient team upping his antihypertensives in the setting of an acute stroke, started getting unilateral weakness as well. There's his MRA, which shows his left vertebral artery pretty much occluded. So that's kind of the sort of problem you can get into when you attribute symptoms to the BP number and utilize this kind of imaginary diagnosis of hypertensive urgency. So,
was the consensus that he had the stroke when he first showed up?
Yeah, and I think
this was vertigo, not like it was vertigo.
It's always Always hard to tell. But yeah, presumably it was vertigo, and it kind of been swept under the rug because of the concentration on the BP number. That sort of seemed to explain everything. But I think retrospectively, it's pretty clear that he had the beginning of his stroke symptoms 2 days earlier when he was admitted, and just sort of worsened, progressed over the following 2 days. That makes sense to me. So, just to conclude, I would say the take-home messages are that high blood pressure is important. High blood pressure is real. Even I acknowledge that. Needs to be treated, but it's a slow actor. It takes, there's a lovely line from The Sun Also Rises, Hemingway novel, where one character asks another,
How'd you go broke?
Yep, how'd you go bankrupt? And he says, 2 ways.
He said gradually, then suddenly.
Yep. It's a great line, and that's really, thank you. It's a great line, and it really applies to a lot of things we see in medicine. You have problems that act slowly, and go on for years and years and years, and all of a sudden they're a problem. And that's true of cholesterol, it's true of smoking, it's true of hypertension as well. And treating the long, gradual damage the same way as the sudden thing that comes at the end is a mistake. Attributing everything that happens along the way to the initial cause is a mistake. And the other thing is that there are no diseases called emergency and urgency. There are just the diseases that we know about. There are acute cardiovascular things like MI and stroke that need to be treated individually, some with reducing BP, others not. There's a slow-moving complication that you could call malignant hypertension if you want, which isn't an emergency in the EM sense, because it takes months to develop. It's bad, but it takes months. That needs to be treated as well. And then there's all these other people who may or may not have symptoms, who have high blood pressure, and please don't attribute their symptoms to their BP. So that's it. Thank you very much. Yeah.
Before you started, so I agree with everything, except the only thing that I was always trained, probably evidence-free as well, and plausibility trained, that there is a level, I'm going to diastolic rather than systolic, blood pressure, beyond which you, at the very least, or not very least, you're concerned that you're going to overwhelm the brain's auto-regulatory mechanism. And that number may, in and of itself, because of the pressure being exerted on the vessels, be potentially dangerous. Not that everyone with that number is going to have a hemorrhagic stroke in the next 24 hours, but you can't really tell. There's no good reason for them to be walking around with a diastolic of 140, and a certain number that are at risk, and therefore that number itself is a reason to lower their blood pressure, bring them in, make sure it's controlled. Not because they're all going to have a stroke, but because they're real risk and you can't predict. And are you just you can't just ignore that number and say, well, go to your doctor next week and maybe it'll come down by a point with the first, and then you'll try to get it in 2 weeks and it'll come down 5 points.
Yeah, no, that's a good point, and I think I didn't show them, but I probably should have. The results of the VA cooperative study, the one from the 60s, kind of apply to that. Here you had a bunch of guys, they're all guys, with exactly that situation, like sky-high diastolics, 130, even higher.
No, I mean,
yeah. But I mean, that's the population that makes us nervous. They were specifically not malignant, right, like papilledema, retinopathy people. Yeah, and so what happened to them over about a year and a half of average follow-up time, they did have 4 deaths. Real, but that's over a year and a half, 70 guys. So bad, and the first bad event was 2 months after they were randomized into their group. So those people could have an event at any moment. They're certainly at substantial risk. You could argue, this is a patient I want to bring in the hospital because it's so important to me that they get this controlled, because sometime in the next few months or a year, they could have a fatal event. It's important. I think it's worthwhile bringing them in, and that's totally reasonable. I mean, that's sort of an operational question. The bad thing is to sort of assume that they have kind of this condition where they have something that, they have vessel changes that they don't actually have, and those are causing complications that those don't cause. So yeah, I mean, I agree. It makes us all kind of nervous. There's actually, there was a study that a group I'm participating in published a few months ago that looked at event rates for patients, sort of trying to get at this, who leave the ED with a diagnosis of hypertension, whatever that may mean. They're probably the people who come in where nothing is found, and that's coded as their diagnosis. I mean, it's an attempt, right? It's an attempt to sort of figure out what happens to these folks, and actually and looking at their ICH event rate, and it's in the month after, it's about 1 in 5,000. It doesn't.
That could be someone who came with blood pressure.
Yeah. It's a very crude attempt to sort of figure out how nervous should we be. Yeah, I mean, 1 in 5,000. Is it bad? It's bad. It's not so bad. Yeah.
No, I was just sort of to the flip side of that. When I was a resident, everybody got a sublingual.
Oh God, sublingual nifedipine. Oh God.
To get that pressure down.
Yep.
And maybe you could speak to why we abandoned doing that.
Yeah. There are a few of us who are old enough to remember sublingual. Does anyone know about sublingual nifedipine in the residence?
Treating that number, man.
Yeah. So, right, there was a rage for this back in the Jurassic. And it was exactly this. I mean, we were giving it, this was kind of around the time I was starting in the ED, we were still using it. So nifedipine, you may or may not know, comes in a little, or used to come in a little squishy orange dissolvable capsule, and it was liquid inside, sort of like a candy, and a hypotensive candy. So what we would do to get faster absorption, and we would do it sometimes for people with just high numbers, because we were all like, it's an urgency, they've got to be treated. Or with people with sky-high blood pressures and complications like strokes. That was like my intern year when my resident would say, we've got to bring this pressure down now. So if you take a needle and you puncture that squishy little capsule, you can squirt the liquid nifedipine under people's tongue to get rapid absorption, which is awesome, except it gives you sudden severe hypotension. And there were adverse events. Let's just say there were some adverse events. The adverse events, actually, I looked into this. And the adverse events were not that many and not that bad. But there were a few. Yeah, I mean, the FDA decided basically to publish a warning saying this was not indicated, it was not beneficial, and could be harmful. And people stopped doing that. But when I started working, people were doing that. I was doing that. I don't think I killed anybody, but I'm not sure. But that's a direct outgrowth, I think, of this kind of, I have to say, sort of ideological fervor for bringing BP down under all circumstances as quickly as possible, because, and with a paucity of evidence, to put it mildly. This idea that BP is everything, and so if there's badness and high BP, got to bring that BP down. Yeah, sublingual nifedipine. It was a hoot. It was a hoot. Not so much for the patients. Any other questions? Any severe disagreements?
Is there any such number? Like
where?
Any number, like at which you wouldn't feel comfortable discharging the patient?
I mean,
women.
Huh?
Pregnant women.
Pregnant women aside, yeah. So pregnant women. So yeah, I mean, there's the exception. This gets complicated, and I don't want to waste all your time. But I think sort of the one exception is people who have things like PRES. So PRES and eclampsia are probably, they're endothelial problems. They're problems with the vessel lining, but it makes the vessel kind of helpless to resist pressure changes. So those are people who, they certainly need the pressure reduced because they do get, cerebral edema and things like that if the pressure is high, even at modest levels. The ultimate problem isn't their high blood pressure, it's really their endothelial problem. You see it in pregnancy, you see it with certain immunosuppressants for whatever reason. And that can develop fairly rapidly, and that maybe is the exception, very rare exception to this sort of algorithm. But to answer your question, the higher the number gets, the more nervous I get. If I see a diastolic of 130, 140, I don't know if I've ever seen 150, maybe transiently, I'm certainly thinking, wow, this patient really has high blood pressure. And then it's up to me to decide. It's not that I think they have an emergency, but I realize with those sort of people, they probably have fairly severe, poorly treated or untreated hypertension, and I have to decide, do I trust them? Do they have a PMD? Are they responsible? I might admit that person, again, not as a emergency, but as a poorly controlled hypertension, and I really worry about this person's, intermediate range future if they don't start getting this treated. A responsible person who has a PMD who I know can be seen and will be treated, I could send them out. I mean, could something happen to them? Yeah, sure, it could happen tomorrow, it could happen a week from now, a month from now. It wouldn't be wrong to bring them in and make sure the treatment got fast-tracked. That would be perfectly legitimate, and certainly the folks like the VA guys, the folks with diastolics in the 120s, 130s, 140s, they have events, in the months following that diagnosis. And so, yeah, you want to get them treated, do what's right for the patient. Sure.
It's also perspective on where you are. Like, I don't see you for Sean. Is Sean? No. But so you talked to some of the guys from Emory. Like Phil Shane came and gave a lecture about hypertensive emergency a couple years ago, because their population in Atlanta tends to run. They have routinely people coming in that you can't even manually get a blood pressure because the
cuff just keeps cycling.
The cuff just keeps going. There's
cycling in
high.
disbelief.
Right, they're just wandering around with blood pressures with systolics in the high 200s, and that's just the way that they live. So I think a little bit of it is also our, the scale of where you are and the demographics of where you are, what's going to get you worried.
Right. Although the flip side of that, of course, is that those are the people who really need to get treated. I mean, those people were like the low-hanging fruit of the early public health initiative to get those fairly young people with really severe hypertension, get them treated.
Yeah, absolutely. But they're just the emergency room criteria may not be a diastolic of 100, which is what
right. We're spoiled. We're spoiled in the Upper East Side downtown.
Think about it. So for them, it's like your diastolic's we're off 140. Let's think about it. It's just a slightly different
threshold. Yeah, absolutely, absolutely. Okay. Thank you very much for putting up with this.
Rich, I would argue that it's not a unicorn, it's a Yeti.